Shweta ma'am, can you stop sharing your slides? I think it is
Sure,
visible
sure,
for
sure.
me.
Stop.
Yeah. Yes, sir. I'm starting the webinar.
Please start.
Yes, in 3, 2, 1. Okay.
Please go ahead.
1 second, sir.
Good evening, respected faculty, and it gives me a great pleasure to just invite both the course director, Dr. P Varma ji and Dr. Vinay Sakhuja ji, for this session 4 of Regain Challenging Cases in Nephrology. So I request Dr. P Varma ji to follow the sir, Dr. Varma ji.
Thank you very much, Deepak. It's a pleasure again to have the 4th session of Regain 3 program. In this, as you all are aware, that we present challenging cases where there has been some challenge in diagnosis or in the management of cases. Today, we have got 2 cases of proliferative glomerulonephritis, and the co-director is my own teacher, Professor Vinay Sakhuja, a doyen in the field of nephrology and a teacher of teachers. And the discussants today are again very erudite, very prolific nephrologist. Both of them, Professor Sree and Raju, who is a senior professor in Nizam Institute, and Professor Pinaki Mukhopadhyay, who is a professor of nephrology at NRS Medical College. Both of them are very dear friends and very lovable teachers and academically sound and experienced, popular among their students. I think the first case, we will request Professor Sree Raju, his student. The students are Dr. Shweta, he is presenting from Nizam, and Dr. Kaushik is presenting from NRS Medical College. May I request Shweta to go ahead. The conduct of the program is the discussants have to discuss the case. And before we start, I'll request Professor Sakhuja to say a few words. We are only moderators and we interject for some queries, but the discussant have to discuss the cases. Professor Sakhuja, sir.
Thank you very much, Professor Varma. So it's a pleasure to be with all of you in this session, and I'm grateful to Micro Labs for sponsoring this program. I think I'd rather not waste any time, and we can go ahead with the first presentation from Nizam's Institute of Medical Sciences, please.
Go ahead, Dr. Shweta.
Just a second, sir. Good evening, respected teachers. May I start?
Please.
Sure. Yes.
So my patient is Mrs. FB, a 32-year-old lady, resident of Chandrapur, homemaker, married since 3 years, nulli gravida, informant being self, denies history of any addictions. Patient has now come to the hospital for a regular session of hemodialysis. I would like to date back my history 2 years ago. Patient was visiting a local practitioner, query for use of native medications for infertility treatment, which she took on and off. At that time, she was diagnosed with hypertension for the first time, with first BP reading being 180 by 110 millimeters of mercury, and was started on some medications. There are no medication details that are available, but she had irregular treatment and irregular follow-up with the same local practitioner. And according to her, the BP was not well controlled. Whenever she visited a doctor, it was always on the higher side. She did not have any headache, nausea, vomiting, urinary symptoms, visual disturbances or weakness, palpitations, muscle cramps when this hypertension was diagnosed for the first time. It was just incidentally detected at that time. At the time of diagnosis of hypertension, patient did not undergo any blood or urine evaluation. And according to her, the BP was not that well controlled. In December 2022, that is after 2 years of detection of hypertension, she developed insidious onset, gradually progressive pedal edema which was up to the knees. The edema was not associated with any skin changes, pain, and was symmetrical. She also noticed some foamy frothy urine. And following that, after two to 3 days, she noticed that there was decrease in the urine output such that she would void only 2 to 3 times per day. This whole symptoms developed over a period of 12 to 14 days. The edema developed first. Following that, she had decrease in urine output after a period of almost 10 days. Am I audible, sir?
Yeah, you are audible.
Oh. So with above complaints, the patient visited a general physician and was further evaluated. She was told to have a raised creatinine of 1.8 milligram per deciliter and was conveyed that she was leaking some blood and proteins in the urine. Hence, for further evaluation, she was referred to nephrologist and then patient came to our hospital. At that point of time, patient did not have any history of fever, sore throat, skin infections, or preceding to this event also. She did not have any back pain, flank pain, dysuria, hematuria, graveluria, or pyuria. There was no history of any photosensitive rashes, arthralgia, hair loss of hair, or oral ulcers. No history of recurrent episodes of any hematuria or dryness of eyes, mouth, and dental caries. No history of any epistaxis, hemoptysis, ear discharge, or earaches. No history of loose motion. She has no history of fever, loss of appetite, or weight loss for a long duration. She denies history of any shortness of breath, chest pain, palpitations, orthopnea, or paroxysmal nocturnal dyspnea. On evaluation, her BP was 180 by 100 millimeters of mercury in both the upper limbs. Her creatinine on OPD basis was 2.5 milligram per deciliter, which increased from 1.8. She had presented to us after 3 days of referral. And proteinuria and hematuria was confirmed. Hence, she was admitted for further evaluation and biopsy. Past history, she is hypertensive since the last 2 years with multiple medications used, irregular follow-up and uncontrolled. No history of diabetes mellitus, thyroid disorder, TB or cardiac disorders. No history of previous surgeries or hospital admissions. Drug history, there is no history of NSAID abuse. There is history of native medication use 2 years ago, before this episode.
Shweta, little slower.
Yes, sir. There is no history of any NSAID abuse. History of native medication use was there 2 years ago, on and off for the infertility complaint. Significant history of hypertension was there in the family. Personal history, she has no addictions and menses were regular for her. So should I go to provisional diagnosis, sir? So on this basis, we had made a provisional diagnosis of acute on CKD or RPRF, RPGN. On the background of chronic hypertension since last 2 years uncontrolled, we had thought the first as acute on CKD and second as RPRF and RPGN in view of hypertension with proteinuria and hematuria. Findings on clinical examination. She had a pulse rate of 88 per minute in right radial artery.
Summarize the history first.
So here is a case of a 32-year-old lady, previously hypertensive since last 2 years, with no other significant complaints in the past, presented with complaints of pedal edema and frothy urine, since last 10 to 12 days, and since 2 days decreased urine output, and referred to us in view of hematuria and proteinuria. So hence a provisional.
Professor Sree Bhushan Raju is around. Professor Sree Bhushan is there, or?
So he's.
Yes, sir. Yes, sir. I'm listening to that.
Achha. All right. Okay. Because I said you have to contact that. Yeah. Go ahead. Yeah.
So on findings in clinical examination, her pulse rate was 88 per minute in right radial artery, regular in rhythm, normal volume, and there was no radial or radiofemoral delay. BP was 160 by 100 millimeters of mercury in both the upper limbs. BP was 160 by 100 in both the upper limbs, checked on the brachial artery in sitting position. There was mild pallor, pedal edema up to the knees. And on systemic examination, no other signs could be elicited on the general examination. In systemic examination, her CVS apex was medial to the midclavicular line in the fourth intercostal space. There was no renal bruit. Chest was clear and she was conscious oriented. On fundus examination, she has grade 1 hypertensive retinopathy. Next, I have.
Shall I, sir, Dr. Varmaji. Sir,
Please.
actually, shall I have to ask the questions or
You have
Dr.
to only. You have to. You are discussing.
Yes, sir. I will discuss actually. Then Dr. Shweta.
Yes, sir.
Your examination history and examination is over.
Yes, sir.
Now you tell me what exactly you wanted to convey. What is the gist of the case, and then just summarize the story and all other things with only positive features and important negative features in a brief way, so that the audience who joined a bit late, they can actually comprehend better.
Yes, sir. She is a young lady, 32-year-old, diagnosed with hypertension incidentally 2 years ago in view of checkup for infertility, and she has taken some native medications, but that was 2 years ago. Now, presently, she came with complaints for the last 10 to 12 days with insidious onset, gradually progressive pedal edema up to the knees, frothyuria, and since 2 days, she is complaining of decreased output. The whole symptomatology, this acute episode is over a period of 10 to 12 days. And she has been told that there is leakage of blood and urine, blood and protein in her urine. So we are suspecting hematuria and proteinuria is there, with history of with background history of hypertension since 2 years, and she has a strong family history of hypertension as well. And on examination, we found that she had a BP of around 160/100. It was equal in both the upper limbs. And she had grade 1 hypertensive retinopathy. In the negative history, she did not have any history suggestive of connective tissue diseases like SLE, wherein she did not have any history of rashes, oral ulcers, or joint pains, arthralgia. She did not have any recent history of fever or sore throat or in the preceding almost.
Telling the entire story again. Please be brief. Actually, summarizing the stories basically to put it in all in 3 to 4 sentences only. What exactly you wanted to convey out of the history? What are the important things which probably can be discussed in the form of a differential diagnosis? Now you tell me a woman, a young woman of 32 years who had a primary infertility, isn't it? Primary infertility, for which she received some native medication. And she was hypertensive otherwise for the past few years with a strong family history also.
Incidentally diagnosed
and
with
she presented to a doctor with anasarca and found to have uncontrolled hypertension of around 180/100 or 160/100, and also azotemia with 1.82 to creatinine approximately.
Yes, sir.
Isn't it? So it's very simple. Otherwise, no other systemic manifestations by any other means. So what do you expect out of this young woman coming to you with such an insidious onset and never had any major significant illness in the past? So what is the differential diagnosis which you would like to convey?
So first, it could be rapidly progressive renal failure. And in the background of active urinary sediment, as per her previous history, hematuria and proteinuria, it could be RBGN. Secondly, I would also like to consider the hypertension previously. It could be a part of underlying renal disease also, as it was a young onset hypertension at the age of 30 years only, and it was uncontrolled. So it could be acute on underlying CKD, some component was there, or RPRF on CKD.
Okay. So why do you think she had a primary infertility? She would have actually visited some of the doctors here and there, and she would have received some kind of contraceptive pills also, including hormone therapies. So do you think the hormone therapy would have actually precipitated her uncontrolled hypertension? And what is the effect of these hormones? And which hormone is more important and significant in producing such an effect on the hypertension leading to uncontrolled hypertension?
So in this case, she denies history of any oral contraceptive pills. She told that there was some native medications. But if we consider use of oral contraceptive pills, they are known to produce hypercoagulable state and can precipitate APLA syndrome or SLE with secondary APLA syndromes also, or can precipitate any protein C or protein S deficiency that can be precipitated, or in case of renal with uncontrolled hypertension and this scenario, we can consider a possibility of thrombotic microangiopathy as well.
Actually, some of the important things which I would like to know from you is the body weight. What is the BMI? Was she an obese woman?
No, sir. She was not. No, sir.
BMI also you should mention. Other one is that all peripheral young woman coming to you with uncontrolled hypertension, otherwise impacting some of the cardiac, especially the renal involvement, you should know whether any kind of a dissection, and you should always tell us there were peripheral pulses also. All peripheral pulses should be palpated, and because one of the important differential diagnoses in this age group is actually the atrioarthritis, isn't it? So we are supposed to tell all the peripheral pulses, including the bruit at the subclavian, carotid, and the renal and renal angle bruit also, not only the epigastric bruit. Okay.
Yes, sir.
And
Yes,
those things actually are missing in your notes. And
okay, sir.
the
I will-
fundus examination is a grade 1 hypertensive retinopathy that shows that she never had a long-standing and hypertension, and not even an uncontrolled malignant kind of hypertension during this particular episode. So those features you can actually comfortably
Yes,
you can
sir.
rule out in this. So what
So
is
I
the differential
there
diagnosis
was
which you would like to think of?
So there was no radial or radiofemoral delay in her, and the BP was equal on both the upper limbs, sir.
Okay,
Hello?
good. So subclavian and all normal?
Subclavian, sir, carotid, dorsal
Subclavian.
tibial arteries, those have been checked, sir. And since there was no radial delay in both upper limbs, assuming that it was both the sides subclavian will also be patent, sir.
Okay then.
Okay, go ahead with the investigation.
Differential diagnosis in a patient coming to you with a rapidly progressive glomerulonephritis.
Sorry, sir, could you please repeat the question, sir?
What is the differential diagnosis for a rapidly progressive glomerulonephritis in this age group?
So the first, since a young female with fertility issues, one of the with a first DD will be lupus nephritis, sir, presenting as RPGN. Second, as the patient is young, second, it could be underlying IgA nephropathy also. Third, it could be ANCA associated. Fourth, it could be either anti-GPM. And down the line, rarely C3GN can also present like this.
Okay, one of the important differential diagnosis is IgA nephropathy. What were the features of IgA nephropathy you would like to elicit in the history since the childhood?
Since the childhood, sir, she did not have any episodes of recurrent hematuria. That would be one of the alarming features. Another thing is she did not have any features suggestive of secondary IgA like chronic diarrhea or arthralgia or arthritis, like to rule out any rheumatoid arthritis or inflammatory bowel disease as a cause of it. She did not have any history of skin rashes or vasculitis rashes. She did not have any ocular complaints. That's it, sir. Main chronic diarrhea and arthritis features and history of recurrent hematuria.
What do you think is the impact of the so-called tonsillitis and the tonsillectomy on the progression and onset and the progression of IgA nephropathy?
Actually, sir, there have been studies in Japan where they have done tonsillectomy for patients with IgA nephropathy. As there is synpharyngitic hematuria, so it is postulated that tonsils will have a role in the progression of the disease. Hence, removal of the tonsils will help prevent disease progression. But this is just accepted in Japanese population and not elsewhere.
Okay, what is the other differentiation which you want to convey?
So I had placed lupus nephritis being a young female, though we could not find anything in the history as.
So how common is the lupus nephritis? A woman coming to you straight with the renal involvement, either in the form of a proteinuria, hematuria, or hematuria proteinuria with renal dysfunction, or without any major systemic manifestations like oral ulcers, hair loss, alopecia, photosensitivity, and discard rash, malar rash, and any other neurological, hematological or neurological manifestation. How common is this? How frequently we see?
As I remember, 10 to 20% patients can present only with renal limited lupus without any other systemic manifestations.
Okay. So what do you think if it were to be the case of, for example, lupus nephritis, what would be the underlying pathology which you would suspect in that?
So autoimmunity with high levels of interferon gamma being the main molecule leading to the pathogenesis of lupus nephritis. Multiple immune mechanisms are there. Multiple antigens will be detected by her as autoimmune, and there will be similar pathology which we can confirm on biopsy in the kidneys.
How sure you are that it is very short and brief history of symptoms for her actually? How sure you are that it is basically nothing to do with any drug-related thing or even native medicine drug-related things rather than a systemic disorder like lupus nephritis and all these things when the patient is asymptomatic totally? So why do you have to? Why do you have to suspect rather?
So
any drug-induced acute intestinal nephritis and those conditions, why you did not think of?
So because the drug exposure is almost 2 years ago, she did not have any recent exposure.
Okay. For the past 2 years, she did not receive any other drug.
No, according to her, she did not receive any other drugs. The antihypertensives also she has received that are also, she did not have the proper documentation, and those were 2 to 3 antihypertensives that also she is taking on and off. And no other history of NSAIDs or PPI used for any other complaints.
Okay. So what else you think of in this case?
Anti-GPM I had thought of, and then ANCA vasculitis and C3GN.
But in the history, you never presented patient had any kind of a difficulty in breathing, hemoptysis and all.
No,
You
sir.
had a plenty of negative history. In that, probably I could not see. Just go back to your negative history, whatever you wanted to show.
There was no history of hemoptysis. There was no history
Yeah, and people have actually asked any other thing related to, if whatever the differential diagnosis which you are going to tell, you are supposed to tell the similar kind of positive or negative history. It can be negative, no problem, but still that indirectly shows that you had that kind of a thing in your mind in the form of differential diagnosis of the case, ultimately which you are going to come out. That the diagnosis may be something different. The most important at the end of the history is a differential diagnosis. So whatever you wanted to tell us, you are supposed to have that. Yeah, there's epistaxis, hemoptysis also, but you have put it in this. Yeah. Okay, but she has a fever, a loss of appetite and weight loss?
No, sir. No constitutional features, nothing.
Okay, all these things are negative histories only.
Negative. No history
Okay.
of this.
Okay. Yes. So what are the other features of anti-GBM which you suspect in this case? What are the features in the favor other than being a rapidly progressive glomerulonephritis as per the history? But what are the features that you can suspect? So is there anything probably you can think of? What is the more presentation and age of onset of anti-GBM syndrome routinely?
The anti-GBM usually has a bimodal peak. It has one peak in the 3rd decade and another peak in the 6th decade. So this lady was in the 3rd decade, though it is said that it is common in males, but she was in 3rd decade. So one age is going in favor that it could be anti-GBM, and another the rapidity of the GFR decline or the presentation of her disease.
You mean that there's a slight deviation from the mode of presentation because of the age is concerned, isn't it? So she
Age
is slightly.
Yes, sir.
Should have been the younger age presentation, which we see routinely the young girls. Okay. And not elderly also at the same time. She doesn't have any other major systemic disorder or a systemic illness to point out that this but could be probably the etiology, isn't it?
Yes, sir.
No other systemic manifestation.
No, sir.
Okay, then go ahead with the presentation, whatever is being done so far in the history in the hospital stay.
After that, she was admitted with us, and these are the investigations which have been done for her. Her hemoglobin was 9.8 with anemia, and WBC platelet count was normal. Creatinine was 2.5 at admission. She had she had mild hyperkalemia. Albumin was normal, 3.6. On complete urine examination, she had albumin of 3+. RBCs were plenty, WBCs being 4 to 5. C3, C4 was normal. Urine for dysmorphic RBC was positive. Anti-nuclear antibody, PR3, MPO were negative, and USG was showing almost normal size kidneys with partially maintained CMD at the time. So we went ahead with a renal biopsy.
Okay. He has a very strong family history of hypertension, and I think consecutive members of the family, successive generations were having hypertension, isn't it? So,
yes,
do you think electrolytes can really throw some light?
Yes, a hypokalemia. If patient is having
elevated creatinine, but do you think the electrolyte would really tell us?
Hypokalemia mainly is associated with endocrine causes of hypertension, like primary aldosteronism or glucocorticoid hypertension. Sorry, sir.
Okay.
So hypokalemia can go in favor of hyperkalemia.
Yes. So she has plenty of RBCs, and also dysmorphic RBCs are positive in urine. Okay. And the kidney size is almost normal, and it maintains CMD. So what is the next step done?
A biopsy was done for her, sir.
Okay.
How did you find the dysmorphic RBCs?
Sorry, sir.
How did you find dysmorphic RBCs?
How did you find?
Pronation of the RBCs will be seen when we send for the evaluation. As per that, there will be dysmorphic RBCs plus acanthocytes and red cell cast on urine microscopy. And
Acanthocytes.
yes.
What percentage of cells should be seen as abnormal or dysmorphic? We call it dysmorphic RBCs.
40% of the cells should be seen as abnormal, 5% as acanthocytes, and 1 as 1 RBC cast.
And how do you see? Under normal microscope? How come?
Under phase contrast microscope.
Was it seen that way?
Yes, sir.
Okay. Found there were dysmorphic RBCs. Okay. Okay. So you felt that it was a glomerular pathology.
Yes, sir.
It was a proliferative glomerulonephritis.
Yes.
And your bet at this moment is what? On some RPGN.
RPGN, sir.
All right. Can it be interstitial nephritis?
No. So interstitial the presence of dysmorphic RBCs goes against
Okay.
acute interstitial nephritis.
Okay.
And proteinuria also, the albumin was 3+. Actually, I have not mentioned here, the 24-hour urine protein was more than 2 grams. So that also goes against the diagnosis of interstitial nephritis.
So if NSAID-induced interstitial nephritis, you can have good amount of proteinuria, you can have RBCs.
Yes, sir.
So is there anything against AIM?
The rapidity of progression, and she denies any history pertaining to.
Your one diagnosis is RPGN. With that, you are going ahead.
Yes, sir.
Okay. Okay. All right. Okay, go ahead. You have done the biopsy. Professor Sakhuja, sir, any comment at this stage for her differential diagnosis? Professor Sakhuja, sir, you are mute.
Yeah, she has probably not considered drug-induced interstitial nephritis because there was no history of any recent drug exposure. But yes, but sometimes that history may not be forthcoming, and yet it might have been there.
Okay.
So one should always keep that in mind.
Okay.
And you've not quantitated the proteinuria in this patient, have you?
It was 2.4 grams, sir. It's not in the slides. 2.4 grams.
Okay, yeah, you hadn't put it on the slide. That's why I was wondering. So 2.4 grams. So that means, yeah, it does suggest glomerular disease, except for with the exception of NSAID-induced toxicity, where you can have significant proteinuria as well, which Dr. P Varma was referring to.
Yes.
So that's fine. And did you you probably did not do the anti-GBM antibodies before the biopsy, did you?
No, sir, it was not done. It was down the suspicion, so it was sent after the biopsy, sir.
After the biopsy.
Yes,
okay, sir. Fine. So you can go ahead with the biopsy report then.
Okay. So actually, a provisional light microscopy report of proliferative glomerulonephritis with crescents was made with a IFTA of 35 to 50%. Patient was given MPs 250 gram into 3 days as there was proliferative disease. We got an IF report after 3 days which showed linear IgG deposits and mesangial deposits of IgA and C3c with kappa and lambda restriction. Hence, serum anti-GBM titers were sent and turned out to be positive. And she was started on plasmapheresis. So this was the biopsy report. There were 10 glomeruli, out of which 4 were sclerosed. 2 glomeruli showed mesangial hypercellularity. 3 glomeruli showed complete cellular crescents. 1 glomeruli was normal. IFTA of 35 to 40% was there. Vessels were normal. On immunofluorescence, IgA 3+ mesangial deposits with IgG linear on the basement membrane 3+, C3c 2+ in the mesangial, and kappa linear BM 2+ and lambda also seen.
So what is your diagnosis
diagnosis
on this biopsy?
Anti-GBM plus IgA with IFTA of 35 to 40% was the reported biopsy.
Okay. So there are complete, the crescents were in a minority of glomeruli, only 30%, but
Yes,
they
sir.
were, and they were all cellular crescents.
Yes.
That's one. Second, you said on immunofluorescence, IgA was E plus with mesangial deposits and IgG linear deposit. I think you are right in diagnosing that it is a dual presentation. Anti-GBM doesn't appear to be very dominant, right? But IgA is also there. Yeah. Okay. How are you going to manage this now?
As the creatinine was less than 5 and crescents were less than 50%, so we started her on plasmapheresis with positive serum antigen anti-IgG.
What do you expect when you are giving plasmapheresis to this person? What do you expect? A good prognosis, bad prognosis? What do you expect?
So if it were to be just anti-GBM disease, we expect a good prognosis. As patient was not dialysis dependent at the presentation, and the number of crescents on the biopsy were also less. So we expect a good prognosis in her, good response to the treatment in her.
Yeah, interestingly, IFTA had become, the crescents were all cellular, but IFTA of 40% was there. That just somehow is not gelling very well. That if the crescents were all fibrous, it possibly was there. IFTA has become this.
She also had 4 out of 10 glomeruli were sclerosed also. So some underlying chronic kidney injury was suspected in her, as she had history of 2 years ago. She was exposed to some native medications, plus she had hypertension, strong family history with uncontrolled in the beginning. So maybe that
What is Dr. Sree Bhushan's comment on this biopsy finding? Professor Sakhuja, sir?
Yes. One question that I'd like to ask Dr. Shweta is,
yes,
what you've told us the biopsy findings. You said there's both IgA nephropathy and anti-GBM disease.
yes,
So, but what do you think is the sequence of events?
So it could be underlying IgA nephropathy, which was there since maybe last 2 years, and now some acute factor that anti-GBM disease has precipitated. So the rapid
that's exactly what I wanted you to clarify. That's what I was thinking also, that probably this patient had a pre-existing IgA nephropathy, maybe ongoing for 2 years or more.
Yeah.
That might have been the cause of the underlying hypertension, and the recent deterioration is because of the anti-GBM disease. So that's how I would interpret it. And it's possible that the interstitial fibrosis, tubular atrophy, and the sclerosed glomeruli are all due to long-standing IgA nephropathy. And in view of that, I think the prognosis may not be very good.
Precisely. That is what
There's
I
likely
wanted
to
her
be
to come up.
chronicity here.
yes, sir.
So
Because
there I would differ with you. The
40%
prognosis may not be that good.
Yes, sir. The answer which I gave, pardon me, it was if it was a single anti-GBM as a disease.
Yeah, then it's fine. For that, yes, if it was just one disease, yes, then it could have been so. But in this patient, I don't think that applies.
So that is what I was asking her. What are you expecting by treating?
Yes.
All right, go ahead. How did you manage? So we are going with the premise that the outcome, we are not expecting it to be too bright.
So Patient was then initiated on plasmapheresis. After 5 sessions, the antibody titers were negative, so plasmapheresis was stopped. She was given injection cyclophosphamide and was told that she will require it every 15 days. She was discharged from hospital with a creatinine of 3.5, a urine output of 800 ml, and reduced pedal edema. She was on regular OPD follow-up. After 3 injections of cyclophosphamide, she was admitted to the hospital to our ICU with complaints of fever, high grade associated with chills and rigor, cough with expectoration, yellow colored, not associated with any hemoptysis, and breathlessness on daily activities. She was admitted to ICU and required NIV support and was told that she was diagnosed with lower respiratory tract infection at that time and required NIV support for a prolonged duration and aggressive antibiotic therapy. And then she was discharged with, on admission, she also had leukopenia. So further dose of cyclophosphamide was deferred. And on evaluation, later she remembers her creatinine to be 4.5 and output around 1 liter and pedal edema up to mid-calves. She was told to have low WBC count and hence further doses of cyclophosphamide could not be given. She was treated with IV antibiotics, NIV, and decrease in immunosuppression. She was discharged with a creatinine of 5 and was advised for creation of artery venous fistula. Patient was then continued on low-dose steroids, angiotensin receptor blockers, CCB, diuretics, bicarbonate supplementation, and erythropoietin supplementation. 1 month post ICU discharge from ICU, her creatinine increased to 6.3 with complaints of fluid overload and uremia, and she was initiated on maintenance hemodialysis via right IJV, and after that creation of arteriovenous fistula. After that, patient had 1 episode of catheter-related bloodstream infection, 21 days post-insertion, and hence another IJV on the other side was placed, and immunosuppression was completely stopped, and steroids were also completely stopped. Patient is now on regular maintenance hemodialysis and is waitlisted for deceased donor renal transplantation.
So, please.
Just one small question. Was when this patient was leukopenic and had a pneumonia, was there something else that could have been done?
She could have been given filgrastim at that time. And
yeah.
So was that done or not?
Filgrastim was given, sir, and steroids were continued, but cyclophosphamide was not given as she had severe sepsis at that time.
Yeah, that is fine, but
Yes,
you did
filgrastim
mention
was given.
filgrastim earlier. Yeah.
Yes, it was
So
given.
that is something that should be done whenever there is infection plus leukopenia combined. That is a situation where you should consider giving filgrastim,
Yes,
because
sir.
it can make the difference between life and death also.
Yes, sir.
So what is the clinico-pathological correlation now, Shweta?
So the clinico-pathological correlation was, it was a rapidly proliferative glomerulonephritis superimposed on IgA nephropathy.
Mentioned before, that in all probability it was an underlying IgA nephropathy.
IgA nephropathy.
Right?
And she progressed because of a dual pathology rather than one single pathology. And though as per guidelines, her creatinine was low, she did not have a lot of crescents and plasmapheresis, everything was done. The disease progressed because of the dual pathology.
Do you think if there is a dual pathology, outcome is better or inferior?
So as per this case and the literature, I think the outcome is poor.
We will ask Professor Raju is there.
So if anti-GBM is associated with ANCA, then outcome will be better because we'll give maintenance as per the ANCA protocol.
How often you find with anti-GBM, ANCA should be positive?
Anti-GBM ANCA positivity, almost 5 to 10% of the cases.
It's much more. It is something like 10, 15 to 50%.
Okay.
It's a big figure. There can be ANCA positivity, and you said that possibly they behave little superior. Likewise, IgA, I am not sure how many series or case reports, but I believe they are supposed to behave better than anti-GBM alone. But in this case, to me, it appears that she had ongoing IgA nephropathy, which was a dominant lesion. And over and above, she developed element of anti-GBM. You treated with plasmapheresis, anti-GBM titer became negative. but you gave cyclophosphamide for almost 2 months, 3 pulses you gave, but logically the improvement was not there. Yeah. Dr. Raju's comments, if he is around. Otherwise, Professor Sakhuja's comments now.
Yeah, I would agree with what General Varma said. So the next question would be, so would you be willing to take her up for a kidney transplant now? And what kind of outcome can you expect?
So if for 6 months the anti-GBM antibody titers are negative, we can still consider her for a transplantation. And IgA also, sir, she did not have. We can go ahead with transplant for her, sir. And for outcome's sake, the chances of recurrence for anti-GBM, if the titers are negative for more than 6 months, are almost negative. And for IgA, she had a bit of a turbulent course because of the double pathology, maybe. So IgA recurrence, as the normal IgA nephropathy patients have, so that is expected in her as well.
Yeah. So what percentage of IgA nephropathies will recur?
So histological recurrence is present in almost 30 to 40% of the cases by the end of 3 to 5 years. But that leading to graft loss is unlikely. Like just like the normal IgA nephropathy will behave, it may have an indolent course, and the graft can work for a longer, can have a long life.
And does anti-GBM also recur?
Sorry, sir?
Does anti-GBM also recurs in transplant patients?
Recurrence is not in cases of.
If the underlying disease is Alport, possibly.
Alport's, yes.
Yeah, then 5 to 10% recurrence is there.
Yes.
But if it is not Alport, it is not there. I think Professor Sree Bhushan Raju's mic is not functioning. We wanted his comments because he is the treating physician. Is he around, Dr. Sree Bhushan?
Yes, sir. Yes, sir.
Please.
Yes, sir. Can you please repeat the question, sir? Sorry.
Yeah, I said your final comments about the case.
Yeah, it is actually unusual that the patients who come to us with anti-GBM disease, and also this is the age for both the differential diagnosis, whatever we discussed, but it's a rare combination of atypical GBM disease with the IgA deposits predominantly seen along with the classical features of anti-GBM. So it's a rare manifestation, but the presentation looks like a very typical and classical of either IgA or even anti-GBM. But it's a combination of these two in this age group of around 30-year-old woman with the hypertension predominantly presentation, followed by anusarca. And probably she did not improve much with the immunosuppressive therapies as well as the plasmapheresis. And this is how probably it behaves. But we don't know much about this methodology and much about this particular disease. And we are supposed to have a series of such cases to know the clinical course and the chronology of events that determine the outcome and the prognosis of these particular cases.
The one question, I think, Professor Raju, for you will be, the question asked is, would crescentic IgA have more recurrence than compared to other types of IgA?
Sir, I'm not able to hear. So there's some overlap of the voice, sir, please.
Yeah, the question is, this patient had crescentic IgA.
Yes, sir.
If a patient has crescentic IgA, like Professor Sakhuja was talking, that 30% or 40% of patients of IgA will have histological recurrence. Will the recurrence be more if a person has crescentic IgA?
She never had such a history of crescentic IgA in the past, sir. She would have had IgA before, but she must be having because she's non-hypertensive, she would have had manifestations of IgA if she happened to undergo biopsies long back. but she never had such a history again to say that it could be a overlap of anti-GBM at this particular time. So this is a condition which is actually atypical anti-GBM, which has got an association with IgA.
I think somebody's mic is organizer.
Yes, sir, actually, I'm not.
Basically, अगर वो तरारी गीज़र कुछ इवनिंग का समझ कर
Organizers, somebody's
वो
mic.
नाइट में साहब इस घंटे
Can you please mute?
आज तो बंद ही कर
either night or daytime, but not during evening.
इवनिंग में शुरू less likely. It is usually current मतलब
Please.
दस
switch
बजे
off the
काम
mic.
ये काम करके पता वो काम करके
This is, yeah. Yeah, Professor Raju.
Yeah, she never had such a history of IgA or IgA crescentic IgA in the past. So it looks like both of them manifested together. She would have had some IgA deposits if I happened to do a
Somebody asked
2 years back.
Somebody asked a hypothetical question that
Yes,
if
sir.
a person has crescentic IgA, is the recurrence more? Anyway, I think we will leave that.
No.
Professor Sakhuja, sir, shall we move to the next case?
Yes, I think we can move to the next case.
I think
Yes.
very nice discussion. Shweta, congratulations, very well presented. We will come back to you again in the end. May I request Dr. Kaushik now
Yes, sir.
to present his case. Dr. Kaushik is from NRS Medical College, Calcutta, and his mentor, Professor Pinaki, is there.
Am I audible,
Hello?
sir? Hello?
Yeah.
Am I audible,
Yes,
sir?
yes, yes,
You are-
yes.
Yes, sir. Sir, my case is 38-year-old lady, housewife by occupation, resident of Kolkata,
वही ये कोशी केस प्रेजेंट कुछ
admitted in nephrology department, NRS Medical College, Kolkata. With three complaints of
Just a minute.
generalized body swelling.
Just a minute. Can you, organizers, microlab organizers, somebody is having crosstalk. Can you please, everybody switch off their mics and let only the speaker have the mic on? Please switch off your mics and make it mute. Go ahead, Dr. Mandal.
Yes, sir. So, generalized body swelling for last 4 weeks and frothy urination for last 4 weeks.
Hmm.
History of present illness, patient developed swelling in periorbital region 4 weeks back, abrupt in onset and gradually progressive in nature and more marked in the morning. The periorbital swelling was followed by bilateral painless pitting pedal swelling extending up to the groin region gradually over next 4 weeks. Next 2 to 3 weeks. Patient had visited local physician and prescribed with some oral medication, following which her urine output was increased and swelling was resolved to some extent. No rise of blood pressures was documented then. It was associated with frothy urination for the last 4 weeks. No history of cola-colored urine, dysuria, nocturia, decreased urine output, nausea, vomiting, abdominal pain, poor appetite, and weight loss. No history of breathlessness, no history chest pain, palpitation, fatigability, syncope. No history of hematemesis, melena, yellowish discoloration of eyes and urine, or diarrhea. No history of joint pain, skin rashes, or oral ulcer was present. No history of fever or recent history of sore throat or skin infection. No history of any other over-the-counter drug intake was present. History of past illness. No history of similar episodes in the past. No known history of hypertension and diabetes was present. Personal history. Patient was educated up to class 8, lived in Pakka house, access to sanitation, dietary habit mixed. No history of any addiction or high-risk behavior, and her sleep and appetite were normal. Family history, no family history of similar illness was present. Menstrual and obstetric history, patient attained menarche at the age of 11 years. Menstrual cycle was regular, presence of no clots. She had history of 2 previous pregnancies with last childbirth 7 years back with normal vaginal delivery. Birth weights of the babies were normal but properly not mentioned. No peripartum complications were documented. Sir, general survey, patient was conscious, alert, cooperative, built normal, nutrition average, decubitus of choice, pallor absent, edema bilateral pitting in nature, painless, present at pedal region up to groin. Cyanosis icterus clubbing was absent, pulse 90 per minute, regular normal volume, arterial wall not palpable, blood pressure 124/80 with no postural drop, neck vein not engorged and neck gland not palpable. Sir, in systemic examination, I did first the genitourinary examination. In genitourinary examination, the inspections, the abdomen scaphoid, umbilicus normal in positions with no venous prominence hernia, though there is valvar edema. Palpation, there is parietal edema present, no renal angle tenderness. Percussion, no significant finding in percussion. Auscultation, no significant finding is present. Renal bruit was absent. Sir, systemic examination, cardiovascular systemic examination, the apex beat was normal in position, normal S1, S2 audible, no pericardial rub. Respiratory system examination, there are bilateral vesicular breath sounds. Nervous system examinations, though no significant findings and no hepatosplenomegaly was found in gastrointestinal system examination. Urine dipstick, it was found blood 2+ and protein 3+. Sir, my syndromic diagnosis was that adult onset nephrotic syndrome, first episode, possibly due to the differential diagnosis are focal segmental glomerulosclerosis, lupus nephritis, IgA nephropathy, membranous nephropathy, membranoproliferative glomerulonephritis. Laboratory investigations, hemoglobin, it was 12 gram%, serum creatinine 0.93 milligram per dl, serum albumin was 2.9 gram per dl, total cholesterol 230 milligram per dl, triglyceride 200 milligram per dl, 24-hour urine protein done, it was 3.5 gram per day. Urine microscopy, the RBC found 8 to 10 per HPF, protein 3+, pus cell 0 to 2 per HPF. The viral serology for HIV, hepatitis B and hepatitis C negative. Immune serology for ANA, ANA profile, ANCA profile, anti-plaque.
Can I stop here?
Yes, sir.
Respected sir, Professor Sakhuja sir and Professor P Varma sir. Yeah.
All yours.
There is a one, and good evening, sir, and pay my regards to both of our mentor. First of, because there is a good discussion on the rapidly proliferative RPGN, and Dr. Bhushan Raju actually discussed in the different aspect. In this, up to this presentation, the first presentation that was much more prominent on the hypertension and the RPGN like picture, but this presentation is much more on the nephrotic type of Dr. Kaushik. Can you summarize the history first?
Sir, 37-year-old Hindu female, not known hypertensive or non-diabetic, homemaker by occupation, presented with abrupt onset, gradually progressive body swelling, which was started from periorbital area, followed by pedal swelling, along with the urination for last 4 weeks without any history of hematuria, dysuria, nocturia, or any other extrarenal manifestation. On general examination, her BP was normal, no pallor, and edema is present up to the groin region. And on urine dipstick, blood 2+
Okay.
and protein 3+.
Okay. Up to this, the summary and the positive findings, according to the DD that you have made, multiple DD, in commonly practice, what will be the come first in this scenario?
Sir, this presentation in 37-year-old female, and the presentation was with generalized body swelling and frothy urination with that manifest over 4 weeks with abrupt onset in nature.
Is there any
I would
history of
like
fever?
to
You have asked for, is there any
make
history
my
of fever and infective focus?
my first provisional diagnosis is focal segmental glomerulosclerosis.
Now, have you asked for any kind of infective focus or leg ulcer or any kind of fever in within a
Yes,
1
sir,
month
I
or
have
so?
already mentioned in my history of present illness. The patient had no history of fever, skin infection, no history of fever, joint pain, oral ulcer, all are absent. I have already mentioned.
And is there any similar episode in any year, 2 years back or any your lifetime?
Sir, in the past illness, I have mentioned that there was no episodes of similar illness.
So this is the first episode.
Yes, sir. This is the first.
Just one point that I'd like to make here.
Yes, sir.
You have put IgA nephropathy as your number 3 differential diagnosis. So, do you feel that is really justified?
Sir, I made this diagnosis, though, sir, nephrotic syndrome-like presentation is IgA nephropathy is very much less. But still, sir, as there is also presence of asymptomatic hematuria and along with proteinuria, and it was seen in almost in 30% of cases of IgA nephropathy. That's why
you have not given the lab findings so far. So far, you are making diagnosis only on clinical history and examination. You do not have lab findings so far. But what Professor Sakhuja is asking you, should you bring membranous as number 2, or you want to bring lupus and IgA number 2? You are saying patient has got nephrotic syndrome, there is swelling up to the groin, so person is bloated up. How common you will have IgA nephropathy with bloating up, and the person is not having any hypertension. Patient
sir, it is rare, comparatively rare.
No. So the question is only sequence. What sequence you will like to put in this differential diagnosis?
Sir, from the history, focal segmental glomerulosclerosis, membranous nephropathy, lupus nephritis.
But membranous nephropathy with asymptomatic hematuria is very minimal.
Hello?
Membranous nephropathy with hematuria is not current, this is not regular feature.
In membranous nephropathy, sir, asymptomatic hematuria is less than 30%. The macroscopic hematuria is less than 4%. It's a minimal. But the age group, sir, actually, the membranous nephropathy usually come at the age group of 4th to 5th decade. That's why I keep it in the downer part.
In case it could be, it is a part of kind of IRGN or PSGN, though fever is, sometimes fever may not be manifested or very prominent because patient have a proteinuria. We have not actually gone through the other slides, but some BP is a 140. It is not normal. It's
it's
bit of higher side.
Sir. It's not 140. The patient is actually normotensive.
140. There's a 1 BP recording 140. Then 120.
124/80, sir.
124/80. Okay.
Yes. So, sir, PSGN is less likely in this case because the history or development of progressive disease over the 4 weeks and not associated with any cola-colored urine, not associated with any hypertension.
Have you taken the history of any indigenous medicine that Professor Sakhuja was rightly pointed out? Sometimes we forget to take the history. Sometimes the patient is having other drugs or indigenous medicine that may lead to, or some working people, they are getting some different purpose. They are taking medicine that can cause a little bit of this type of symptoms.
Yes, sir.
So is there any possibilities of any drug induced all these things can be interpreted, all these things?
Sir, though no drug history, I have asked the patient and the patient had not said that there was any significant drug history, except patient had taken some oral medication for her current symptoms by local physician, possibly diuretics. But yeah, if I miss the diagnosis, there is possibility some drug associated causes of nephrotic syndrome, like
which are the common drugs that
NSAIDs.
can cause this type of presentation? Which are the common drugs that is
NSAID, sir, can cause
and also
commonly used drug.
proteinuria.
NSAID, sir, can cause nephrotic syndrome.
Or other drugs?
Uncommon drugs like, sir, penicillamine.
Okay.
Yes. Sir, Sree sir, go through.
I think we can go. We can go ahead.
Go ahead. And then you just with this summary of the history and also the that is a positive findings. You have keep this patient as a syndromic diagnosis and nephrotic syndrome. With a special reference, you are putting the focal segmental as the first choice, and the lupus is the second choice, and IgA is the third choice.
Yes, sir.
So, what are the investigation should you prescribe according to the importance of the patient?
Sir, I should go for initially go for blood investigations like complete blood hemogram, sodium, potassium, urea, creatinine, liver function tests, and then immune markers. Of course,
Sodium, potassium, how it will help in this patient for the diagnosis? You should have be very much specific. The investigation.
Sir, viral serological markers.
Diagnosis.
Okay, sir. Viral serological markers. I should look for hepatitis B, hepatitis C, and also, sir, immune markers like ANA profile, ANCA profile, anti-plateau antibody.
If the patient is the creatinine is normal, otherwise patient is a nephrotic proteinuria, should we send all the patient with the ANCA, C-ANCA, P-ANCA, and the anti-GBM? What is the common practice?
Sir, ANA profile.
Should we send all the patient, irrespective of the normal renal function, from the first day, you will send all the investigation?
No, sir. ANA in this patient, sir, ANA profile, anti-plateau antibody will be relevant. C3, C4. I have to look for.
So, what is AG ratio, albumin globulin ratio, in this patient?
Sir, in this patient, sir, serum albumin was 2.9 gram per dl. Globulin was 3.5 gram per dl.
And what was the hemoglobin level?
Sir, hemoglobin level was normal, 12 gram %.
Hemoglobin level is normal. So, there is a altered AG ratio. Cholesterol is little bit high. So, it is a very much clean-cut picture of the adult onset nephrotic syndrome for the first time.
Yes, sir.
Sir, can you ask the question? You can ask, sir, if you ask.
No, I think let him bring the investigations, what he did, and let's interpret the investigations. Go ahead, Dr. Mandal.
Go ahead.
Yeah.
Sir, her 24-hour urine protein was 3.5 gram per day. Urine microscopy, it was RBC 8 to 10 per HPF, protein 3 plus. Viral serology was negative. Immune serology, sir, all are negative with C3, C4 normal. On ultrasonography, sir, kidney size was normal CMD, no hydronephrosis. Sir, then we have planned for
before biopsy, you just go ahead, go behind. Before biopsy, go behind. Can you just suspect this type of adult nephrotic syndrome with RBC, apart from the FSGS or IgA, what are the other, if is anything can you strike your brain is possible? Because there is no suggestive of any infection.
Sir, in case of the lupus nephritis, there may be possibility of presence of RBC in the urine. Even, sir, in membranoproliferative.
The patient is having a concomitant stone disease also. That can may you sometimes RBC with
But
some
sir,
dual pathology,
as it-
definitely.
Hello.
I think Dr. Mandal, with this
Because
profile,
the renal
you
function
have-
is normal.
you have excluded lupus. You have excluded by and large the anti-PLA2 negative means what are the chances of membranous still there? If
Sir,
anti-PLA2
yeah, there are still chances of membranous nephropathy.
What
Because in
of-
sir, primary membranous nephropathy, it is 70 to 80% cases anti-PLA2 positive.
That's all right. So by and large, you are excluding membranous and lupus with this. So your possibility remains at the moment. You feel that it could be FSGS. The patient has RBCs, hematuria. There is a nephrotic syndrome. Your suspicion of FSGS is valid. Now, the patient is not hypertensive, keep in mind.
Yes,
So
sir.
in MPGN, generally you find hypertension. In FSGS also there is some element of hypertension, but that is an odd feature. The hypertension is not there and renal functions are absolutely normal.
Yes.
Dr. Sakhuja, sir, your comment at this stage.
Yeah, the only one point that I'd like to comment on is the presence of RBCs in the urine sediment. 8 to 10 RBCs per high power field. Now, this is not a usual feature of either FSGS or membranous nephropathy. So, this is something which should lead one to think of other possibilities. And obviously, MPGN would be one of them. Lupus nephritis would be another one, but lupus is ruled out because the ANA has already been done and it is negative. So I think this is one feature that one should keep in mind that does not fit with classical FSGS or membranous nephropathy.
Yeah.
May I proceed, sir?
So, proceed, sir.
So I think, yeah. So you went ahead with the biopsy.
Sir,
Go
this
ahead.
is the light microscopic finding. There, this picture is given that there is 20 glomeruli, one globally sclerosed, one showed focal segmental sclerosis. Remaining glomeruli showed mesangial expansion and mesangial deposits are PAS weakly positive, weakly argyriophilic with Congo negative. IPTA 10%, focal extravasations of intratubular proteinaceous material with surrounding inflammatory response, intraluminal hyaline casts in tubular lamina. Arterial show focal subendothelial hyalinosis. Immunofluorescence study, sir, IgG3 positive, mesangial confluent present, IgG2 positive, rest negative, C31 positive, kappa lambda each was 22 plus. And DNA JB9, the immunohistochemistry done, that showing the DNA JB9 positivity confluent in the mesangial area.
Achha, Dr. Kaushik.
Yes, sir.
If suppose the DNA GB9 positive, sometimes special cells, sometimes it is not routinely done in the different center. Till except the DNA GB9 positive, with the if you can explain these things, what will be your diagnosis? Except GNB positive.
Sir, if we exclude DNA JB9 positivity from the light microscopic finding, there is some mesangial depositions. Mesangial depositions it is found. And this we have to go, we have to differentiate the etiologies of these mesangial expansions. These mesangial expansions may be congruent positive and may be congruent negative. If it is congruent positive, it was amyloidosis. But if it is congruent negative, so then I have to go through the immunofluorescence study. If immunofluorescence study is negative, the possibility, though the patient is non-diabetic, the possibility of diabetes will be there. If it is immunofluorescence positive, then we have few differential diagnoses in our hand, like light chain deposition disease, fibrilloid glomerulonephritis, and immunotactoid glomerulonephritis, and cryoglobulinemia.
So
Those are
why is
the
this not?
diabetes. In
Professor,
diabetes, there will be pairs.
Professor Sakhuja, sir, can you just comment on this slide?
Sir?
Yeah, I wanted to ask Dr. Mandal, why is this not FSGS now? That was your first diagnosis clinically. Can this biopsy fit in with focal segmental glomerulosclerosis?
Sir, there was one focal sclerosis was there, but there was also, sir, mesangial expansion.
Okay, so the mesangial expansion or the deposition of some material in the mesangium is taking you away from FSGS. But is there something else also which takes you away from FSGS? What about the immunofluorescence findings?
Dr. Mandal, what is IF?
So the
Sir,
immunofluorescence?
yes, sir. There is immunofluorescence positivity, IgG3, IgG2, C3.
So are these features of FSGS?
No, sir.
No, yes. So that is the main thing that should take you away from the diagnosis of FSGS. In FSGS, you may only have scanty deposits of IgM and C3 in the sclerotic areas. Otherwise, you don't have anything else.
Yes, sir.
So if you have IgG 3+, then that goes totally against the diagnosis of focal segmental glomerulosclerosis.
Yes, sir.
So that is more important than the mesangial deposits.
And by showing us DNJB9, you are clinched the diagnosis. All right. What is this? Can you just tell us DNJB9 positivity?
Just
Sir, DNA-JB9 positivity is quite diagnostic of fibrillary glomerulonephritis. It is found in fibrillary glomerulonephritis. It is the co-chaperone protein which is deposited along with immunoglobulin G in the mesangial area and found in immunohistochemistry in fibrillary glomerulonephritis biopsy.
What is the specificity and sensitivity of this test?
Sir, it is more than 95%, I think. I actually don't know, sir.
99%.
99%.
It is almost diagnostic, isn't it? I thought...
electron microscopy picture.
Now, you must have done electron microscopy for
Electron
about...
microscopy is there?
Sir, electron microscopy was there.
Okay, go ahead.
Sir, it is seen that there is significant podocyte food process effacement. The mesangial and subendothelial region expansion occupied by aggregated non-branching fibrillary structures measuring 16.8 to 27 nanometer diameter, though extraglomerular deposits are not seen. So serum protein electrophoresis and immunofixation as well as bone marrow examination was done, which shows normal study.
So you have got fibrils of diameter 20 nanometer.
Yes, sir.
Conforming to fibrillary.
Yes, sir.
What is the diameter size in amyloid?
Sir, in amyloid, it is about 5 to 10 nanometer fibrils.
And immunotactoid?
It was, sir, 30 to 50 nanometer fiber, microtubules.
Okay. So I think, Dr. Pinaki, I think the moment he found...
There's a one thing that is a way. That is fibrillary glomerulonephritis is sometimes it is difficult to diagnose. If they suppose in all the centers, if they don't do the DNA JB19, then it is very difficult because if you don't take this stain, this patient will be treated as IgA nephropathy or by FSGS, this type of category. So the question is that what will be the take-home message? In all the cases of the alert nephrotic syndrome?
The question is, he has already found some deposits amorphous deposits which are Congo red negative in the mesangium. That always raised the suspicion that you are having some deposits. If it was Congo red positive, it was simple amyloid.
Amyloids,
negative, logically, you are talking of fibrillary or this. And what you are saying, DNJB9, I am not sure this is a recent progress. I don't know how many years back, possibly a decade or so back. Before that, it was never there. And because of that, many cases of fibrillary were missed that time.
Out.
They were missed that time. And sometimes there are some people who have got a mild staining of Congo red also. They used to be treated as amyloid without a definite diagnosis because the amorphous material was there. And the size of the fibril it can ranging from almost 10 to 30. So, which was just closing to amyloid. So people were giving a wrong diagnosis, but definitely the message you are giving is DNJB9 is a stain, is the staining, if it is done, if it is positive, it is clinching the diagnosis these days. Your comments now.
There is one issue, another issue is there, that is the fibrillary glomerulinephritis can present in the wide variety of the glomerular presentation, coming from the mesengoproliferative, membranoproliferative, diffuse sclerosing. And so it is very difficult to particular pinpoint the presentation. And the thing is that regarding the treatment, because Dr. Kaushik, how do you approach this patient for the treatment point of view?
Sir,
before he goes for treatment, once you have clinched the diagnosis of fibrillary, what is the outcome?
Outcome.
Sir, there are high chances of end-stage renal disease within 2 to 6 years after diagnosis. And sir, regarding transplantation, though there are no definite literature was there, but the recurrence rate was also high in fibrillary glomerulonephritis. I have found, sir, one literature where they did 5 transplant in fibrillary glomerulonephritis patient, and 4 of them have recurrent disease.
But was the not? So is it recurrence of fibrillary lesions?
No. So is it a contraindication to transplantation? Would you refuse transplantation, or would you still consider it?
Sir, I would still consider it because though it was also seen that in most of the cases, though there are chances of recurrences, the chance of recurrence is high, but the disease progression or symptomatic manifestation are not as robust as the primary disease.
Yeah, I can quote you a figure of one series of patients with fibrillary GN who underwent transplantation. There was a recurrence rate of 36% at 51 months after transplantation. So it is not an absolute contraindication, but yes, there is a significant risk of recurrence of the disease, right? So transplantation can be offered to these patients.
Sorry, please.
The one other point with regard to diagnosis, I just want to emphasize, we've already talked about DNA JB9 and the importance of EM. So if you have DNA JB9 immunohistochemistry, then you don't even need electron microscopy. You can confirm the diagnosis without electron microscopy. That is the important point to know, because even electron microscopy is not routinely done on all biopsies and not available in all centers at all. So that's why the importance of knowing this.
I think we give it to Dr. Pinaki. What is new in the management of fibrillary and any progress? Like you manage your case.
How you approach this patient? Because initially it was thought of a very pure adult nephrotic stenopath first, but when you came to know it is a fibrillary, how will you approach in this group of patient?
Sir, yeah, initially we given trial of oral steroid 1 milligram per kg per day, and for 3 months it was given, but there are no reduction of proteinuria. Rather, we have to discontinue the treatment due to toxicity. Thereafter, we have started injection rituximab 500 milligram IV, 2 doses given 15 days apart. And thereafter, patient was follow up in our OPD for last 5 months, and her proteinuria level is still less than 500 milligram per day with normal renal function. Sir,
Do you
I
believe
found in the
rituximab is a very
literature
potent
that
agent for the treatment?
sir, actually the role of steroids and other immunosuppressants is not so good in the treatment of fibrillary glomerulonephritis, but rituximab can be given and it had showed some improvement in the features of patient.
So is it the first line treatment
Clearly,
now?
the patient having a 2 dose, but recurrence is almost 80%, and complete remission only the 10 to 30%, and partial remission around 10%. So rituximab, though it is seems to be lucrative, it is may not actually purpose the problem. Sir, can you comment on this?
Yeah, so the treatment is with immunosuppression is quite disappointing. There is no good evidence that immunosuppression works in these patients. I think we need much more experience with rituximab before we can really recommend it to our patients. So I don't think there is any real basis as yet for using it in all patients. One other point that I'd like to make is that there are a lot of conditions that have been found to be associated with a fibrillary glomerulonephritis. So
Yes, sir.
would Dr. Kaushik like to comment on that?
Sir, fibrillary
What are the
glomerulonephritis.
association disease?
Sir, HCV infections, lymphoproliferative disorder, monoclonal gammopathy.
Yes.
These are the associated features.
Yeah. Besides that, even autoimmune diseases.
Hepatitis.
Yes.
Yeah. HCV, you have already mentioned, diabetes mellitus and malignancy. So these are the ones that you should remember. So besides HCV and paraproteinemias, right? You in fact look for paraproteinemias in this patient also.
Yes, yeah.
So you have done that test. But I don't think a bone marrow was really justified in this patient. If you had found a paraproteinemia, then it might have been justified. But in the absence of that, I don't think.
Actually, kappa lambda ratio was high. Kappa lambda ratio was very high. That's why that seems to be very much maybe some other bone marrow involvement.
Lymphoproliferative disorders, sir.
Yeah. And in fact, it has been shown that in those who have a paraproteinemia, you may have light chain restriction on immunofluorescence also.
Yes.
So that correlation has also been described. And one more question, what is the IgG subtype that is found in these patients?
Mandal?
Sir, IgG1, IgG3.
3? No, it's IgG1 and IgG4. But 4 is more common than 1 also. You can find both IgG1 and IgG4. You don't find IgG2 or 3, right? And 4 is more than IgG1. So that is the classical picture.
And also associated with the malignancy as well, carcinoma.
Yes, malignancy. I mentioned malignancy, yes.
Yeah. Yes, sir.
Malignancy is also well known.
Is Sree Bhushan Raju also there?
Yes, sir. Yes, sir. I've been listening to
I
that.
think your comments are also
We
reported.
have recently good number of cases of fibrillary, 3 or 4 cases. Interesting thing is that all these patients were actually having associated systemic disorder in the form of type 2 diabetes. In fact, we have done for the atypical manifestations of type 2 diabetes, and we have done a diabetic nephropathy evaluation, and as a part of the diabetic individual biopsy, and we found that the fibrillary glomerulonephritis, and one patient only we could treat them with the rituximab. And there's not much of improvement. But when patient is maintaining a very stable renal function with a conservative treatment without much difficulty. So the clinical course, the outcome has to be seen, but there's some few studies are there already, but still we need to know the clinical course in a long way.
I think, Professor Sakhuja, sir, we can conclude. The time is up also.
Yes, I think we can conclude the session.
I think both the cases by Professor Raju's team and Dr. Pinaki's team have been wonderfully discussed, and I congratulate the students. Both of them did a good job of presenting, and they were ready with the required answers. And both the cases were fascinating. One first case, anti-GBM disease, which was never suspected. Neither IgA was suspected nor the anti-GBM was suspected. And unfortunately, the outcome was dismal. And the second case, again, it was never suspected. It was an adult onset nephrotic syndrome, and it turned out to be fibrillary glomerulonephritis. And DNJB9 gave a diagnosis, though they did an electron microscopy also. But as Professor Sakhuja mentioned, it may not be required today if the immunohistochemistry is positive. The management of fibrillary glomerulonephritis still remains an enigma. The trials with rituximab, one has to see how the results are. The associations of fibrillary with whether malignancy or diabetes or lymphoproliferative disorders needs to be kept in mind. HCV infection, hepatitis B infection has to be cryoglobulinemia, needs to be kept in mind. And overall, I think it has been a good learning for me. And from both the discussant and Professor Sakhuja, I'll request Professor Sakhuja to conclude the session, please. Professor Sakhuja, sir.
I would largely agree with the sentiments expressed by General Varma. I think we've had a good discussion, very interesting cases, though relatively rare problems, but certainly you have to deal with all kinds of rare problems also when you work in any specialty. So I'd like to finish by thanking Microlabs once again and all my faculty colleagues and the students for their participation. Thank you very much indeed.
I'm glad to tell them that over 100 people had joined the interesting session. That only shows Dr. Pinaki's and Dr. Sree Bhushan's popularity. Needless to say, it is Dr. Sakhuja's popularity which draws the crowd.
No.
Next week, we are having 2 transplant cases which are being presented by Gangaram Hospital. So see you next week. Till then, Professor Sakhuja, sir, good evening and good evening, friends.
Good evening,
Thank you. Thank you very much.
Thank you, sir.
Thank you.
Take our pranam, sir.
Good evening, sir.
Good evening.
Good evening.